of the Maryland Optometric Association and has received numerous accolades, including Optometrist of the Year from the Maryland Optometric Association. He's an international speaker and published author. He specializes in technology, AI, telemedicine, and practice management. He also holds degrees in mathematics, optometry, business administration, healthcare management, as well as data analytics. And so, Dr. Rogoff, it's such a pleasure to have you here this evening.
Thank you so much. No, it's a pleasure here, and it's good to be able to talk about this technology that I think a lot of people have been waiting to see finally come to light, where they can start to really use it in a way that's going to help patients clinically.
Completely
So,
agree. I'm so excited.
so Dr. Major, I know that certainly there's a component that everyone's always interested in terms of when it comes to reimbursements and payments, and a lot of people have been waiting a long time for this code because this technology is not new. It has been around for a little bit, but I know that, of course, when we start to think about workflow and the efficiency and what we need to do for our patients, this actually has a very good clinical component where some people may not have been able to obtain it due to that it does have a little bit more expense to it. But now that the systems, especially CMS, have come forward and have cooperated with a couple of with the AMA as well as RUC committees and some of the other types of associations, now starting as January 1st of 2025, there is a separate reimbursement code. And so I know a lot of people have been waiting around for this code to come about. So just to give a little bit of background, so that had to go through the AMA pushed it forward because obviously we'll talk about more of the clinical applications, especially you, Dr. Major, about how you're using OCTA in your current workflows, especially at the university, and seeing what patients and what disease states you're really finding this to be helpful for. But now knowing that it's a separate code, because understanding the retinal vasculature has so many implications, not only on the ocular disease in the retina, but we know that that in turn affects a lot of the systemic disease. So just to let everyone know that Medicare has been doing these releases. And additionally, both the AAO, the American Academy of Ophthalmology, as well as the AOA, has been prepping with a lot of the discussion in their billing coding type of resources that they put out for the members about this upcoming code. So one of the great things is that has come about it is that because it does require usually a little bit more understanding and a lot more interpretation, is that the 92137 code has been added to this whole portion of being able to understand OCT from a vascular perspective. Currently, CMS has released everything accordingly. They came out with their final rule in November, and everything is now published on their website as far as what the new global code is going to be. And for surprising some folks, as we always know that some reimbursements do go down, this is to start out as a global code of about almost $57. Now that does vary upon different types of other portions of the RVU. And of course, when it comes to the commercial plans, that we always tell people to check with their payers, as sometimes they do follow suit. So I think really, I mean, I would love to understand, Dr. Major, from your perspective, how, is this going to really change some of the workflow when you start to see patients that require OCT from last year to this year? And great to hear how you're starting to use OCT, especially at the university level, and getting those students on board to understanding the importance of OCTA.
Yeah, absolutely. I think it's so exciting now that we have this new code for OCT angiography. And I've been using Zeiss OCT angiography for many, many years because I've seen a huge benefit in the quality of patient care, that it makes you far more confident in knowing, say, for example, you have a patient with diabetic retinopathy and you're thinking, oh, maybe it's severe non-proliferative, and feeling confident in that versus early proliferative diabetic retinopathy. And so I think just having that extra confidence adds a lot in terms of your patient care. It's also helped me detect some of the earliest neovascularization, not only in like proliferative diabetic retinopathy. And I think like all of the diabetic retinopathy codes are going to be huge in terms of like billing OCT angiography, but also macular degeneration and detecting those earliest neovascular membranes and macular degeneration that we can't even see yet because they aren't leaking fluid, they aren't leaking blood. The only way we can actually see them is using OCT angiography. And so using these diabetic retinopathy codes, I think macular degeneration codes in order to bill OCT angiography, which is going to pay more than just our regular retina code now. And then also retinal venous occlusive disease, I think, are another set of codes like branch retinal vein occlusion, central retinal vein occlusion are going to be really huge in terms of using those to bill OCT angiography moving forward.
It's great to hear about the other types of use cases that we typically may not use on a structural OCT. So you mentioned some of those other type of vascular occlusions and arteritic occlusions. Have you been currently using OCTA when you start to see those patients?
Yes, so I find a whole lot of value in using the Zeiss OCT angiography and evaluating patients, especially with retinal venous occlusive disease. I think Dr. Rodman hit this as well. Like, we cannot visualize retinal non-perfusion on clinical examination typically, unless it's very acute and like the retina is white and opaque and pale. In those later stages of the occlusion, that goes away. And so we're only able to really visualize that retinal non-perfusion with OCT angiography technology. And estimating that degree of retinal non-perfusion helps you say, is this ischemic or non-ischemic? And we know that ischemic vein occlusions tend to carry this risk of being complicated by neovascularization, whether it's in the posterior segment in a branch occlusion or the anterior segment in neovascular glaucoma and central retinal vein occlusions. So there's a lot of value there. And in looking at the macular region for macular ischemia. Again, I think Dr. Rodman hit some really great cases of patients with diabetes and retinal venous occlusive disease where there's macular ischemia present that's, accounting for a patient's decrease in best corrected visual acuity. Yet we can't see that clinically, right? So we really need some angiography technology. And OCTA is actually superior to fluorescein angiography in detecting that because of that high microvascular resolution detail that we get of the foveal vascular zone.
So you brought up a very good aspect of when we do, and I get some of these questions posed to me about, the billing portion. Now, I can't give actual billing and coding information. I just refer to the resources. So
Mhm.
it's very interesting that the NCCI and as well as the AMA have given out some languages that when you bill for OCTA, you're not supposed to be billing for those other types of imaging. However, you can still do it on a separate claim for the fluorescein angiography and ICG and the combo codes. Um, us as optometrists, I've not had access to be able to see some of perfusion without this technology. Do you think that we're going to be using this a lot more? And even things like when we start to think of neurodegenerative disorders such as glaucoma, have you started using some of this technology for some of those type of disease states?
Yeah, I think there's a lot of application in optic nerve diseases as well, like you're saying, glaucoma, ischemic optic neuropathies. I don't use it as much as I do for like retinal or macular diseases, however, but I think that's definitely like another tool that you have in your tool belt in order to sort of diagnose early glaucoma and monitor for progression and change over time.
That's great. Now, as far as the setting that you're currently in with the university, I mean, I know that some universities do touch upon how to be able to properly put in their ICD-10s and their CPT codes. And certainly, is that something where the university is focused on making sure that the students are going to be at least have a working knowledge of how to be able to do this? And has this already started since the beginning of the year, since this new code has been out?
Sure, yeah, we definitely try to equip our students with the best resources possible to set them up for success as soon as they graduate from our program. And so certainly proper billing and coding is part of that. It is not something I particularly teach as it is not my forte. I'm more in terms of like retinal disease interpretation, management, imaging, things like that. But it's definitely something that we try to push and emphasize as a very important thing to know to make money once you graduate.
Excellent. So I think some things are coming in through the chat here. I know that I'm kind of looking back and forth on. I guess in some of the other things that you mentioned that you're teaching there, and when it comes towards this OCTA angiography, um, can you think of there's incidences where you would run an OCTA separately by itself, or are you always running it along with a structural type of code if it's 92133 for optic nerve or 92134 for the retina?
Yeah, so I think the beauty of OCT and geography is that you also get some of that structural imaging and you can kind of view those simultaneously side by side, which is a huge advantage because then you can kind of draw these correlations between abnormal structure and the vascular component. So like, let's say, for example, on the structure, you see there's some cystoid macular edema or like a serous pigment epithelial detachment or something. You're saying, well, where is that fluid coming from? You can then draw on the vascular information to say, oh, there's a neovascular membrane here, or there's some ERMA here that's likely contributing to that pathology. And so there are certain instances like looking for neovascularization in macular degeneration, where I may just do an OCT angiography scan. I don't have to take a separate scan to get that structural information, but it's now with this new billing code, it's something where I may alternate, right? So I may bring a patient back again in like 2 or 3 months who's particularly high risk and then run just the OCT so that I can, kind of take advantage of both of those codes.
And in the clinic, in terms of, especially for the ocular disease side of things, is there a particular workflow where some of these patients that are either new patients coming on into the clinic or if they're returning, are you already setting them up uh, with those orders saying I need to have a structural scan as well as an OCTA exam prior for them to come in seeing the you as the attending or the student?
In my particular practice here at the university, it's kind of on a patient, like customized level. So kind of assessing the patient case, and then the student will come and present to us, and we decide like what imaging would be best, and allow the student to weigh in on that and kind of value, that decision making in terms of what's most important. Like if you had to pick just one test, what's going to be the most valuable in terms of helping you determine the management that's most appropriate for that patient. So it's really a patient dependent process for us at the university. But I see a lot of value in setting like protocols. If you're in like a high volume, private practice setting or ODMD setting, setting some sort of protocol, that way your technician knows exactly what to run for this particular condition, whether it's macular degeneration, diabetic retinopathy, retinal venous occlusive disease. And even those, macular diseases that maybe OCT angiography isn't as valuable, say like epiretinal membrane, vitreomacular traction syndrome, that you already have sort of a protocol established so that your technician can really do that imaging, take advantage of it, and your high efficiency in your practice. There's something else that has added a whole lot of value in my workflow has been the incorporation of Zeiss Forum review software so that, like OCT and OCT angiography, it's such a dynamic view and interpretation, right? We get this volumetric 3D cube of data, but then our like PDF printout is like a 2D printout. And if you don't scan through it, like actually through the data, especially in macular degeneration, you could be missing some fluid that would be indicative of like exudative conversion and potentially a patient that needs referred for like anti-VEGF therapy. And so I think there's a whole lot of value in order to be like just sitting at my workstation and not have to go to the machine and be able to scroll through the entire cube of data. Or for OCT angiography, to be able to kind of click through those different preset NFOS displays so I can very easily maneuver and go from superficial to deep to the outer retina choriocapillaris, for example. As I've really enjoyed incorporating like Zeiss form review software in my practice as well.
So I'm really glad that you brought upon that because I know, especially when it comes to making clinical diagnoses, especially progression analysis of a disease state, this is going to be super important where you can always have those static reports and to be able to view them one by one. But having a data management system like Zeiss Form, or there's other competitors out there as well, to be able to take some of those cubes and actually display and see what's actually happening over time. And OCTA is one of those things where you can start to really see that vascular changes. So I imagine you've been really incorporating that not only just to see the structural scan, of course, there's glaucoma workplace that Zeiss offers to be able to take the structural scans as well as the functional scans and line them up to be able to understand exactly how the disease is progressing. So
Mhm.
it sounds like you've been doing that with some of those things. So if it comes to resolution with maybe a vein occlusion, but I'm sure understanding a little bit more when it comes to diabetic retinopathy, if it is getting worse, if there's a net forming, you did run an OCTA, and now you're starting to see some changes in that vasculature.
Yeah, I've seen a lot of value there, and there's been some really interesting research and publications regarding like the morphologic patterns of choroidal neovascular membranes in terms of whether they're active or like inactive that can help you kind of guide as to whether this patient needs additional anti-VEGF therapy or is this just an inactive membrane that I can monitor. And so like assessing that change over time with therapy has been really valuable.
Excellent. And I know that as far as OCTA, I know that that's how long have you actually had that at the university to be able to start using? When did you
Oh
start
goodness.
applying?
I've been actually using Zeiss OCT and geography since it came out. Gosh, I want to say it probably like 10 years or so. Although I've only been here at the university in Oklahoma for about like 4 or 5 years, but I am no stranger to serious OCT and geography, that's for sure.
I know that it probably was discussed in the previous lecture as well, but I know that due to understanding, especially interpretation, that's why Medicare and the RUC committee actually put a lot of RVUs against the interpretation portion of it as well as the practice expense, because it does cost a little bit more than your typical structural OCT. But understanding that interpretation, I think um, we're going to probably start to see a lot more education wrapped around
Yeah.
it now that it is a separate code and understanding the vasculature. There's been plenty of studies that have been out there regarding known as the use, but now knowing how to efficiently insert into the workflow is going to be very, very critical. So, I mean, it's great to hear about some of the clinical uses and where you see some of that going. And I know that it all starts with the education, of course, when it comes to the students. And I know that a lot of the folks probably who have been attending the CE certainly appreciate the fact of understanding when to start to use OCT and knowing now it is a separate code. Now, of course, when it comes to being able to have a new code out there, something does have to give way. So some of the other OCT codes, the 92132, which is the anterior segment, 133, which is optic nerve, and 134 did get a lower reimbursement as to be able to fit for this vasculature portion of that. So I know that it's going to be crucial to be able to know when you be able to do 92137 for when those are for those patients who actually are going to need to have that vasculature. So I guess just to understand, I guess overall, I mean, when we start to think about the what we did what we did OCTA for previously. Are you going to see anything happening any differently from a practice perspective, or do you see when you go out and you lecture and you hear other people's clinical cases, do you see anything where you say, oh, they should run an OCTA, especially when it comes to some of the panels and the grand rounds? Do you see that
Yeah.
missed a lot?
I think there's been like more of an awakening for me in terms of like utilizing it as soon as there's some unexplained decrease in best corrected visual acuity. Like even if your regular structural OCT looks like relatively normal, or maybe there's just some small abnormalities, OCT angiography can show you a lot, like we saw in patients with diabetes, like seeing changes in the foveovascular zone very early. But also I picked up a lot of patients with like early macular telangiectasia type 2 that had like a decrease in vision of like 20/30 that was otherwise like unexplained. And so, I think in some of these like more rare type of diseases, but I mean still seen clinically, it really helps you have an explanation as to like why the visual acuity and visual function is affected when the retina otherwise looks normal.
And that's something great where I know that unfortunately the code is new. It just came out just several weeks back. And certainly there's usually articles that Medicare will post out to understand what ICD-10s would go along with the medical necessity of OCTA. But I think you just brought up something very interesting because on the structural side, when we don't see diabetic retinopathy, I mean, typically we're not running an OCT on that for the putting in for a claim. But it does have a lot of clinical use to understand that. And certainly if you're not understanding why visual acuity is not correcting down to the best visual acuity the patient was previously, running an OCTA might be able to uncover that. So clinically, it does have a little bit different use case than our traditional types of imaging that we have available. Just as an opinion question, I know that the profession has really pushed the envelope in terms of what we are trying to do as far as wellness, especially for those new patients coming on in. So a while back, especially when wide field imaging became available, and certainly Zeiss had their class camera available, and so we started to do fundus imaging just to make sure that we have documentation and a clear understanding of how the vessels look, and having that versus just being able to document in our medical records. Then some folks have even moved towards OCT as a different way for wellness to understand how the structure is first, see if anything's starting to up and coming that we may not be able to see just on direct visualization with the slit lamp and VIO. And some have combined that. Do you think, especially for the OCTA, I mean, it's now adds a little bit more towards the arsenal, especially for optometry, where we won't see vasculature type of changes unless we're sending out for fluoresceins and ICGs when it comes to that. I mean, what's your opinion about doing that for wellness and along with some of the other ones?
I think that would be an excellent incorporation into a wellness scan. Like here at the university, it's been very rural setting. So like I very rarely see a patient who is well for, usually they're being referred to me for some sort of retinal disease or glaucoma or something like that. But I admire so much those individuals in like private practice settings who are doing and offering like a wellness examination, because I think that's a great extra source of income for the practice. And the patients really appreciate it too. And you'd be amazed at some of the things that like you pick up. Like I hear stories about them picking up like a visual field defect that ended up being a brain tumor or something. I mean, there's miraculous things that come through those sort of wellness exams. It almost makes you question, like, should this be standard of care to begin with? And why isn't insurance and Medicare not paying for it? To be honest.
No, that's great to hear. I know we're coming towards the end of the hour. I know some folks have been on late, and I think we have a Q&A that some things might have come into the chat. See if we can answer before the end of the hour. Thank
Yeah,
you so much.
I'll take it over from here. Thank you so much, Brian and Dr. Major. Good evening, everyone. Thank you so much for joining us. I am Kimberly Pasola from Zeiss, and I am moderating the Q&A. So I just have one question for the audience before we get into your questions. Has anyone billed and been reimbursed for the 92137 OCTA code? Please let us know in the webinar chat. Okay, now on to your questions. Our first question is for Dr. Major. Can you discuss your practice workflow when OCTA takes a little bit longer and possibly might need to be redone if the patient moves?
Oh, certainly. I find that being like a rare occurrence because the Zeiss Sears models have motion tracking, and leaving the motion tracking on is critically important to getting a valuable OCT angiography scan because we're basically imaging red blood cell motion. And so motion artifacts are going to be highly detrimental to your scan. But the motion tracking software that's already embedded in those systems helps eliminate a lot of that. So I don't typically have to redo scans for any reason. I think like lubrication artificial tears goes a long way for any OCT scan that you're doing prior to taking the scan. But in terms of like workflow, I mean, I've been using it for the past 10 years and incorporating it like seamlessly. And our students really, I think, have been well trained, and you could train your technicians in a private practice setting too, to know like, well, if a patient has like high risk intermediate stage macular degeneration, oh, this is a patient that I need to do OCT angiography on. So it's really been like a seamless transition for me.
Okay, great. That's wonderful to hear. The other question now is for Brian. Can we bill OCTA and OCT macula at the same visit? I think you already answered that, but can you restate it again?
Sure. So there is some literature that is out there from the AMA and from the NCCI edits that have been put out there. So if you're performing both OCT, the structure for retina from 92134, and then you're also performing an OCTA, which would be the code 92137, you're only supposed to bill for one, very much like it was for retinal imaging and OCTA. You're actually taking two images. Sometimes it is necessary to make a clinical decision, but you're only supposed to be billing one. That was very explicit when the RUC committee did submit this in for AOA, and everything was agreed upon. So unfortunately, only one OCT code is allowed to be billed on that visit.
And to just clarify, that will also include retinal photos.
Correct. So I think it hasn't been explicitly been put in the literature yet. However, that kind of is grandfathered from the previous OCT and the retinal imaging codes. You're only supposed to do one or the other.
Okay, thank you very much. All right, our next question, again for you, Brian, is what or where can I find the ICD-10 codes that would justify OCTA?
So this has been a question that, as I've been speaking about this, has been widely asked. And of course, we always want to make sure that we are billing accordingly to the medical necessity for the code, so we can make sure that we're not going to get audited, and to make sure we're going to be reimbursed in a timely fashion. Medicare has not listed out the ICD-10 codes explicitly. However, the way the definition does read is that is an OCT of the retina, including angiography. So I would say there's no reason to suspect that Medicare would not pay for something where you need to make a clinical decision by using OCTA, using the 92137 code. So basically, from what has been discussed out in the community, and I've spoken with other types of consultants, it seems that what you've been doing previously, if you've been doing 92134 and then also doing an OCTA, you're only billing 92134 before. So as those codes become very prominent of that does have ICD-10 codes, at this point, that's what we're seeing from what's been reported back from other types of physicians that have been using OCTA. But there are no articles that have been explicitly listed for ICD-10s specifically for OCTA. Now, we always say to use as a resource, I mean, if you're billing Medicare, you have your local MAC and your Medicare administrator, people that you can always get in contact with. And especially if this is a commercial type of plan that you're going to bill, is to get in touch with those payers, as there might be some local types of restrictions or something where they may not see something. They usually will get back to you when it comes to that type of information.
Okay, thank you. And if there is any more questions, we'll be closing out the session.
If I could ask you a question, Dr. Rogoff, if you don't mind. No, I've kind of heard in other webinars and that I've been listening to that it may not be reimbursed if you're doing it for an optic nerve disease because like the description says like retina. Do you have any input on that?
Not at this time. It's so early to tell. It just went live literally January 1st. And I do have access to a lot of different databases with different clearinghouses to kind of see who's putting in. It doesn't tell you what claims get adjudicated and get paid out in terms of that, but at least you can start to see, and it's just too early to tell. Obviously, and that's why I was asking more about that clinical side to see exactly. I mean, it might be a clinical component which might make its way to an ICD-10 list later on, as we already know. The OCT-10s for diabetics only includes the retinopathy, but we know that there is a clinical use case, especially if there's unexplained loss of visual acuity without the presence of retinopathy, where OCTA might help. So, and optic nerve is another one when it comes to glaucoma, understanding that vasculature. I'm sure there's going to be a lot of studies that come along afterwards that are going to probably get into those articles where it's going to be part of that ICD-10 code list that would make it medically necessary to be able to bill that 92137. But time will tell.
Thank you. Good. I think that's all the questions that we have here this evening. I want to thank you so much, Zeiss, again, for sponsoring this awesome CE presentation that we had from Dr. Rodman that really helped prime us in incorporating OCT and Zeiss Cirrus OCT angiography into our clinical practice. And Zeiss also put up a QR code here that they will give you a special offer on the Zeiss Cirrus OCT angiography on the Cirrus 6000 model if you want to scan the QR code and specifically mention Wu University so that you can receive your special offer. And Dr. Rogoff, it was such a pleasure having you here this evening for this and your expertise. Thank you so much for joining us.
Thank you. I appreciate it, Dr. Major. Thank you again.
Great. So thank you, Zeiss, and everybody have a great evening and Bill OCT and Geography.